I am by no means a doctor or in the medical field, so bear with me on my pronunciation, but I will do my best. So first up, we have Dr. D'Amato doing our Cancer and Sarcoma 101's discussion. Dr. D'Amato is an associate professor of medicine at the Sylvester Comprehensive Cancer Center at the University of Miami, where she serves as a sarcoma medical oncologist, assistant director of clinical research, medical director of nurse practitioner oncology fellowship program, and medical director of patient education. She also serves as the co-director of Oncology and Related Health Disparities Pathway and co-director of Oncology Pathology Advanced Integrative Science elective at the University of Miami Miller School of Medicine. She received her bachelor's degree from the University of Miami, her MD from the University of Miami School of Medicine, and completed her internal medicine residency at Jackson Memorial Hospital and University of Miami. In 2003, during her last year of hematology oncology fellowship at Moffitt Cancer Center in Tampa, Florida, she began her focus on sarcomas, including GIST and benign connective tissue tumors such as desmoid tumor, chordoma, and giant cell tumors. All right, we're super excited to feature Gina today. Gina, are you on the call? I know we're running a little bit early, so maybe we need to do a quick little break here. All right, let's go ahead and pause, actually do a quick break, make sure Gina is ready, and then we'll get started in just a few minutes. Thanks for your patience. All right, I think we have Dr. D'Amato here now. Are you ready to take it away?
Give me 1 second here. Hold on. All right, so you need me to share my screen?
I will just click through for you if that works.
Okay, you got my slides?
Yeah.
Okay. All right, well, thanks for having me. I just got back from the hospital rounding, so I'm a little disheveled, but hopefully you guys will be fine with that. So I'm going to go over a little bit of cancer 101 and sarcoma. So what is cancer? So basically, cancer is uncontrolled growth of abnormal cells in the body. So, you have your normal cells and then the cells that become abnormal, and if they grow and divide, it's cancer. So the cancerous cells are also called malignant cells, and the cancer develops from normal cells. So the normal cells somehow become abnormal, and there are genes and proteins that are responsible for cell division. And so, for example, if you cut your arm and you need to make new skin cells, the genes that are responsible for making new skin cells get activated. And then you make new skin cells, 2 become 4, 4 become 8, you make like 1,000. And then you have genes to say, okay, I've made enough. And the cells and you made enough. Okay, I no longer need these cells anymore. And it stops. But what happens with cancer is that these systems are mutated, so the cancer the abnormal cells continue to grow. So, and they multiply when the body needs them, and they die either if they're abnormal or the body doesn't need them anymore. So basically, cancer appears to grow when the cell growth is out of control, and also they forget to die. And there's many different kinds of cancers, and they can develop from any cell in your body, mostly organs or tissues, lung, colon, breast, etc. Next slide. And so there's oncology is the study of cancer, and an oncologist is a doctor that treats cancers, and also the doctor is always on call. But anyways, that's my bad joke. But anyway, so and they call it oncologist probably because, in the past they used to whisper cancer, but now we say it out loud, so we're fine, but we still go with oncologist. And there's many different ways to treat cancer. So we have different kinds of doctors. So we have a surgical oncologist that does surgery residency and then does a fellowship in oncology. We have an orthopedic oncologist that's an orthopedic and then does a fellowship in oncology, a head and neck surgeon, a urological oncologist, and then those are doctors that deal with surgeries. And then we have doctors that deal with medications, or what we call systemic therapy. So we have the hematologist oncologist. We do 3 years of internal medicine residency, and then we do a fellowship in hematology oncology. And then or a pediatric, you do pediatrics for 3 years, and then you do hematology oncology. And then a radiation oncologist, a doctor that uses radiation, does his own residency. And then you have gynecologist oncologists that not only deal with, they do surgeries and they give chemotherapy. And they deal with uterine and ovarian cancers and cancers of the GYN tract. Next slide. So again, healthy cells represent the smallest functional unit of our existence, and they have 2 parts. They have 2 main parts. They have the nucleus that holds the genes, and then the cytoplasm, which is the worker bee. And again, they grow and divide, and each cell, they all have the same gene. We all have the same gene pattern that's unique to us individual, but not all of those genes are turned on in every single cell. So like the genes that are responsible for liver function are turned on in the liver. The genes that are responsible for the stomach are turned on in the stomach. Okay. And what holds the genes, the DNA, is the DNA, the genetic material. And also your immune system regulates this process. Next slide. So this is back from biology, but some of us remember it, others do not. But again, when the cells need to be growing and dividing, they line up the genes. You get 23 from your parents, 23 from your mom, 23 from your dad, and you have 23 pairs. And when it's time to grow and divide, they line up and they're supposed to divide specifically, and the same genes are supposed to be in each cell, but sometimes there can be abnormalities called mutations. And if there's mutations in the genes that are responsible for cell division, cancer can form. Next slide. So again, 2 become 4, 4 become 8. And so we need to know this because when we use treatments, different treatments target these different systems. So again, normal cell division, 2 becomes 4, and then there's a damaged cell. It's supposed to undergo apoptosis or programmed cell death. But what happens in cancer, these abnormal cells continue to grow. And so a normal cell has these receptors called growth factor receptors that they get turned on. A normal cell has a couple of them, they get turned on, but a cancer cell has a lot of these receptors, so it keeps getting turned on. Next slide. And so cancer can form either from a precancer, like a colon cancer forms from a polyp, or it can just start out of nowhere. Okay. And so here are some examples of, and when it's a clump of cells, it's called a tumor. Okay. Next slide. So tumors are a clump of abnormal cells, but not are a clump of cells. So benign tumors, it's not cancer. That means they can still invade into things. So someone's saying they can't see the slides. I don't know if anyone else can see the slides. Are we having problems with seeing slides, or is everyone seeing these slides?
Is there anyone else that's unable to see them? Just let me know in the chat box.
Okay. All right. Everyone. Right. Okay, good. Okay.
I'll just continue and I'll.
Okay. Sorry. Okay. Sorry. Sorry, I got distracted. That's my ADD. But anyways, okay. So we have a benign tumor that's a clump of cells, but they can push on things and they can be painful, but they don't have the ability to go through the bloodstream and invade and spread somewhere, or through the lymph system to invade and spread somewhere. So malignant tumors are cancer, and they are usually rapidly growing, and they can invade local tissue, and they can spread when a malignant tumor or cancer tumor spreads away from the original site, that's called a metastasis. Next slide. So again, cancer cells have the ability to spread through another location in the body, either locally in the same area or distally away from the original through either the bloodstream or the lymph system. So this is just a picture of the lymph system, and then you have a picture of the circulatory system. So that's how it's spread. So for example, a sarcoma could start out in the leg and go up the bloodstream and go to the lung, because it goes through the bloodstream. Next slide. So different terms. So we divide cancers into solid tumors or by liquid tumors or hematologic malignancies, or the system, like is it lung, colon? So next slide. So again, you have your solid tumors that usually start out from organs, and you have carcinomas, which start out from lung or liver or colon, And then you have sarcomas that start out from connective tissue. And then you have melanomas that start out from the skin cells that make your pigment. And then you can have then you can have brain. Okay, and then you have the hematologic malignancies or the blood cancers. And the lymphomas start out from lymph nodes, leukemias start out from the bone marrow and wind up in the blood. Multiple myeloma also it starts out in the bone marrow. And you have some pre-cancers that start out in the bone marrow. Next slide. So again, cancers are named after what we think the original cell is. So adeno means a gland. So adenocarcinoma of the colon is the glands. And then liver, hepato, lipo, fat, erythro, red blood cells, chondro, cartilage, melano, the pigmented cell, myo is muscle, osteo, bone. Next slide. So again, the different types. So carcinomas are the most common types of cancers. So it starts out from either skin or tissues that line internal organs or epithelial cells. Sarcoma is a cancer of bone, cartilage, fat, muscle, blood vessels, or connective tissue, which we'll talk about. Melanoma, again, the skin cells. You have leukemia that starts out in white blood cells, and lymphoma from the lymph nodes. So the immature cells of the bone marrow will be a leukemia, and the mature white blood cells that are in your lymph nodes is a lymphoma. Next slide. So the incidence rate, so this is the number of newly diagnosed cancer every year. This is not the prevalence people living with cancer, because there's a lot of people living with cancer that have been cured of cancer or living with it if they haven't been cured. This is the number of new patients every year. And I just updated the slides late last night. And I've been giving this lecture for many years, and it started out with 1.4, 1.6. Last year, it was 1.8. And now it's a 1.9 million Americans will be diagnosed. And then breast cancer, 300,000. So that's up. It's been kind of slowly going up. Breast cancer rate was about 240 and then 280. And so we just went over to the 300. Soft tissue sarcomas and bone sarcomas, they've kind of creeped up a little bit, but not as much as some of the other cancers. Slightly more common, so 13,000 as opposed to 300,000 with breast cancer. A little bit more predominance in the men than women, and then bone as well. Again, bone affects younger patients. So about total of about 18,000, just shy of 18,000, 17,000 patients with sarcoma diagnosed every year. Of course, that's rare, about 1% of all cancers. Of course, I don't think it's rare, and that's why we're having this meeting. And so we can let you guys feel that it's not, we don't think it's as rare as, we don't want you to feel like it's rare, even though they say it's rare. Next slide. How do you diagnose cancer? You diagnose cancer with a biopsy. So that's basically where you take a sample of a tumor and a tissue and look under the microscope. You can do it with an FNA, which is a fine needle aspiration where they just take a few cells, or you can get a core where you have a big chunk where they can really see it. Sometimes it's difficult to get to the biopsy, so they do an excisional or incisional where you have to actually have it by the surgeon. Sometimes you get a biopsy through using a camera, either an endoscopy or a bronchoscopy where they're looking at something in the lung. You'd get a camera down your windpipe, or a colonoscopy. You got the camera looking at your colon and they can sample. Those are for things that you're looking on the inside. For the outside, you need to get it. You need to get a needle going to the outside. Sometimes it's really hard to get the tumor out. So they have to actually, or to biopsy, they actually have to open you up. And that's what's called an open surgical exploration or a laparotomy. Next slide. So what are some of the cancer terms? So these are all like the same kind of synonyms. Okay. So a nodule or a lesion, this can be used interchangeably. Nodule, like say if you see something on a scan, it'll say a lot nodule. That means they don't really think that it's cancer. They don't know. Usually if they say lesion, they think maybe it's cancer, but they still don't know. So they use those terms interchangeably. It's usually they're describing something that's less than 5 centimeters on a scan. A mass, also a lump, can be used interchangeably as well. And a mass is something that can be internal or external. And a lump is something that you can feel. A mass, you don't necessarily feel. So it's more the description. And then typically they tend to be big, a lump, usually over 5 centimeters or a mass. And then the staging is where the cancer is in the body. So it's based on the size of the tumor, the grade of the tumor, which is when the pathologist looks under the microscope, and if it has spread. And then grading, again, is the pathology term, looking at how it looks like under the microscope. So those three things make up the staging: the size, the grade, the location, and whether it's spread or not. Next slide. So types of treatment. So the types of treatment that we have are based on where the cancer is, what kind of cancer it is. So surgery just removes it, right? Radiation will also target it. And then we have some interventional radiology techniques, radiofrequency ablation. Those are just targeted to one area. Then we have systemic, which means medication that's dispersed throughout the body, okay? So you have chemotherapy, which basically chemicals that kill cells while they're growing and dividing. You have targeted therapy, where it tries to stop the signals that are leading to the abnormal growth. And then immunotherapy, where they're stimulating your immune system to fight the cancer. So that's why if we understand how the cancer cell's working, we can figure out, different targeted treatments based on that. So chemotherapy really is non-specific, but there's many different kinds of chemotherapy regimens that are specific for certain types of cancers. And then molecular therapy or targeted therapy, we have to know what system is being turned on, what system is being turned on so that we can shut it down. And that's when we do special molecular tests to see that. And then immunotherapy, we block the current immunotherapies. We're blocking the cancer cell from tricking the immune system. Right now, the cancer cells have receptors that trick the immune system not to fight them. So the medications that we have block that system so the immune system can recognize the cancer cell and kill it. Next slide. So again, some other terms. Cure means that you've received treatment for cancer and it hasn't recurred, it hasn't come back that we can see in 5 years. Okay. Remission means that you've received treatment and the cancer hasn't returned, but it's been less than 5 years. Now these are these terms, these are more medical, and these, are kind of fluid terms, but you've been hearing these terms. So no evidence of disease means that we divide cancers into curable or treatable. Curable means that there's something that we can give you and that it can eliminate the cancer totally from your body and never come back. And that's usually stage 1, 2, or 3. And so if you've received treatment for a curable cancer and it hasn't come back in less than 5 years, remission, more than 5 years, then it's cured. Okay. If it's called no evidence of disease, say you have your cancer spread, but you receive treatment and you can't see the cancer, but it's spread. So we call it no evidence of disease. Okay. We can't see it. Metastatic means that it has spread from one area, and it's spread either through the bloodstream or the lymph system. And treatable, again, curable is and treatable are different. Treatable means metastatic or stage 4. So stage 4, it means that the primary tumor is unable to be removed or it's spread to other areas. But you can have it in just one little area, lymph node, and be stage 4. You can have cancer all over the body and be stage 4. So stage 4 kind of has a bad connotation. So that's why I like to just say treatable or curable. Complete response means that you've received treatment and you can't see the tumor anymore. Partial response is that you've received treatment, but it's decreased by 30 to 50%. Stable disease means you receive treatment, nothing's growing and nothing is new. And then progressive disease means that the cancer has grown by 20% or there's something new developed. And we use those terms when we're describing in the literature. Next slide. So other cancer terms, hereditary means that there's a gene that was passed on from your relatives or your parents that contributed or caused the cancer. And genetics refers to the abnormality in the genes causing or seen in the cancer. So when we send the tumor specimen out for genetic or molecular profiling, that's just the genes seen in the tumor. We don't know if those genes were hereditary, passed on, or just sporadic, meaning it just developed. Okay. Indolent means slow growing. Aggressive is usually fast growing or quality of life or life threatening. Next slide. So the most important cancer term in the world is hope. That's what Sarcoma Alliance gives us. So you're not alone. That's some cancer terms. Now we'll move a little bit on sarcoma terms. Because I have, I think, about 7 minutes or something like that. So since I got a little early, I can go a little over. Yeah. So sarcoma is from the Greek meaning fleshy, or especially referring to fish flesh. And it's a group of tumors that arise from the mesenchyme or connective tissue. Next slide, please. So again, when you are in utero, so when the baby is being formed and the body is being formed, it starts out with just, 2 cells, and then they split and then they form 3 layers. The ectoderm, which is the outside, the mesoderm, the inside, the middle, and then the inside cells. And those inside cells, the endoderm, make up epithelial cells that make up your organs, like colon, lung, prostate, liver. And those cells, if they develop into cancer, it's called a carcinoma. And then you have the middle layer that makes up your connective tissue cells, bone, muscle, fat. Those are the middle layer, also makes your bone marrow. So, and then you have your ectoderm, the skin cells. So it's interesting that children don't get breast cancer or colon cancer, but they can get leukemias or lymphomas and sarcomas. That we think it's because probably from that middle layer, they probably share different genes. Next slide. So again, you have the primitive cell called the mesenchymal cell, and then it differentiates into connective tissue, osteocytes, bone, cartilage, chondrocytes, muscles, and tendons. Next slide. And so again, I forgot to update this one, but so I'll update this slide. But again, we saw this one was from 2020, the slides, but again, we went over this incidence. Also the average age is 55, which is a lot younger than patients that get other types of cancers. Next slide. So most causes are unknown. We do know some causes, prior radiation from other cancers, for example, breast cancer, Hodgkin's lymphoma, some cervical cancers, or even benign tumors. Usually if it's from the radiation, it happens about 3 to 23 years after the radiation, and average is about 10 to 13. This is not radiation from regular x-rays and CAT scans. I know a lot of people worry about that. This is actually radiation for treatment of cancer. But even though it could have caused by cancer, sometimes we still can give radiation to treat the sarcoma. Chemical toxins, so we know some herbal phenyl herbicides like Agent Orange, some wood preservatives, pesticides, not a little bit amount of pesticides, but say someone owns a pesticide company and has had a lot of exposure to pesticides, that's more where we see it. Patient and we have even had some patients where the father was exposed to Agent Orange in Vietnam and they developed a sarcoma. Tamoxifen, which is a medicine that we give for breast cancer, that can cause uterine sarcomas. Next slide. And we have some hereditary syndromes where you have Li-Fumani syndrome, where there's a lot of patients with the family members with breast and brain and leukemias. And then retinoblastoma, neurofibromatosis, which is a disease where you have these benign neurofibromas, but there's about a 15% chance that one of them can mutate and to turn into a sarcoma. Next slide. And the sarcomas are named after what we think the original cell is. So for example, leiomyosarcoma is a smooth muscle. So you have skeletal muscles that you contract voluntarily. And those, if it's from a skeletal muscle, it's called a rhabdomyosarcoma. But internally, you have smooth muscles that contract involuntarily, like your heart and your uterus and blood vessels that push the blood. So those, if it's from a smooth muscle, it's a leiomyosarcoma. Fat, liposarcoma, osteosarcoma from the bone, chondrosarcoma from the cartilage. And then sometimes we don't know what the original connective tissue cell is. So then the pathologist will describe it under the microscope. So like epithelioid sarcoma, for example, it just looks like, oid means looks like. So they look like epithelial cells, which tend to be a little bit rounder. Alveolar soft part sarcoma, for example, they look a little bit like the lung cells, but that has nothing to do with lungs. And then synovial sarcoma, for example, was thought to be from the fluid, the joint fluid, but then they realized it's not from the joint fluid, but they never changed the name. Next slide. So again, sarcomas can be divided into soft tissue or bone. Soft tissue, there's over 150 there's about 170 different kinds of sarcomas because we're learning more and more about the sarcomas and the genetics of them. So we keep getting them separated. Initially, when I first gave this talk, it was 50 and now 100, now 170. And they can either look, and they're called spindle cell, meaning that they look long and thin like muscle cells. Some that can be growing very rapidly look like small round blue cells. And then we have the bone, which is osteosarcoma, bone sarcoma, chondrosarcoma, and Ewing sarcoma. And then solitary fibrous tumor, we don't know the cell of origin for solitary fibrous tumor. So it was just, it's kind of, it was described on how it formed, even though it could spread. It's called solitary, so some of these names don't even really make sense. Solitary fibrous tumor was originally called hemangiopericytoma, and hemangiopericytoma was like the cells that surround some blood vessels. And so we think that it may be from some cells that surround blood vessels, but we still don't know for sure. Okay, next slide. And then this is kind of how the pathology, when they do a sample, they do certain stains, and the purple is the nucleus and the pink is the cytoplasm, and if there's a lot of cell growth, then there's going to be a lot of purple. So normally you wouldn't see the nucleus in normal non-dividing cells, you see a few. So leiomyosarcoma, they describe this herringbone, and pleomorphic means many size and shapes, so there's no rhyme or reason to that pattern. Angiosarcoma, there's little red areas, you could see blood vessels, and then liposarcoma, you have these hollow areas that look like fat. And then there's different kinds of liposarcomas. And so depending on how it looks like under the microscope in certain tests. And next slide. Oh, so yeah, so are there any studies that links between glycophosphate exposure and sarcoma or liposarcoma? We haven't, so we are doing some, we're trying to get some surveys done, questionnaires with our patients to see a lot of things, we have theories about, but we haven't been able to prove that in sarcoma because they're rare. Also, liposarcoma is interesting because it's a fat cell, so you think, oh, maybe someone obese would be at more risk, but it doesn't matter based on obesity. You could be very thin and have a liposarcoma, or heavy and be a liposarcoma. So it's very interesting. The bone sarcomas, you have either extraskeletal Ewing sarcoma, these are the small round blue cell. These tend to be very quick growing, and we need to treat with chemotherapy. So Ewing sarcoma, rhabdomyosarcoma, and synovial sarcoma. Next slide. And then bone sarcomas, you have either the osteosarcoma, Ewing sarcoma, or chondrosarcoma. So Ewing sarcoma could either start out in the bone or the soft tissue. We know it's a Ewing's, how it looks like under the microscope, and it has a specific gene mutation. Next slide. And then this is the incidence by the type. So we have GIST is the most common type of sarcoma. It used to not be the most common type of sarcoma, but now we have really good treatments for it. And so all of a sudden now it's one of the more common types. So as we get better treatments, we may see increased rates of things, but GIST is the most common. And then we have unclassified. So a lot of them, we just don't know the original cell. Liposarcoma, leiomyosarcoma, they're one of the most common. And then so we have about Ewing sarcoma, rhabdomyosarcoma, angiosarcoma, a blood vessel. So we have about 50% of the sarcomas are the most common, and then we have the rest quite rare. Next slide. Again, I think this is the same slide by accident. Okay, next slide. UPS would be the unclassified. So unclassified yes. So that's one of the more common types. We have GIST, which starts out from the GI tract. So you have your GI tract, which is your esophagus, stomach, and colon and small intestine. So the most common location is of the stomach, but you can have it of the small intestine or colon or esophagus. And it tends to spread differently than the extremity sarcomas or the retroperitoneal sarcomas. Next slide. And then a soft tissue sarcoma or a bone sarcoma usually starts out with just swelling, okay? And only a third of the patients present with pain, so there's often a delay in diagnosis. No one knows about sarcomas, so then, if you see some swelling, you may, and it's not painful, you think maybe it's a pulled muscle or infection, and then you go, so you're like, well, maybe I should eventually go to the doctor, then eventually go to the doctor, and then the doctor is like, I never learned about sarcoma in med school, and I'm going to go with the most common, it's a pulled muscle. And so then, or it looks like a hematoma, a collection of red blood cells. And so it takes sometimes the patient about 6 months to make a diagnosis, to go to the doctor, and then the doctor another 6 months. So there's a delay in the diagnosis. And most start out in the arms or legs, mostly in the up and the lower, because you have more legs than arms, right? And that's where most of your connective tissue, but about 20% can start out in the abdomen or pelvis, what we call the retroperitoneal area. Could happen in the head and neck area, or about 9% of the head and neck area. But again, it can happen anywhere. It could even start in one of your organs. Next slide. And usually what we have to do is we like to see where the cancer is, and we like to get, if there's a mass in your extremity, we like to get MRIs. And then If it's in the abdomen and pelvis, we get CAT scan, the chest, abdomen, and pelvis. Next slide. And because I ran out of time, so then, this conference is going to be talking about different treatments, so I didn't focus on the treatments. I wanted to just give you a little bit of overview so you can understand all the terms, going forward with this meeting, so you can really understand everything. And should pathology for unclassified be checked periodically to see if it can make more specified? We're going to learn about how it's important to be looked at by a sarcoma expert. So we do recommend anybody with a pathology that has a sarcoma, we want that pathology to be reviewed by an expert sarcoma pathologist. So usually if your tumor's been looked at by an expert pathologist and it still says unclassified or undifferentiated, that's usually the diagnosis, and actually you can qualify for studies just having that, but then they can also send for some molecular testing to see if they can then further define it. And then what type of, okay, let's see, blah, blah, blah. Okay, should the pathology be, I have a very rare pecoma. Sorry, I didn't bring this. How many other patients have this kind? There's so pecomas are one of the more rare kind. But given how rare it is, there's actually a treatment that's FDA approved for pecoma. But I would say I think it's about 1 in a million. I think that's the rate, maybe a little bit less. And so maybe like I think 100 or 200, maybe 100 new cases in the US each year. And if the type of sarcoma is not known, how does that impact treatment and options for decisions? Again, if it's an unknown kind, it's still called like pleomorphic undifferentiated, and there are trials that look at those. So, as long as it's looked at by a sarcoma pathologist, they will name it. And even if it's called unknown, it still shouldn't necessarily affect your treatment, because we have several treatments just for those unknown kind. And how often should scans treatment be done, if NED, over 20 years? So 20 years is a long time. Usually when we do surveillance scans, we usually stop at 10, but depends, depends on that would be an individual basis. Sometimes I have patients that I've seen that have had it over 10 years. I may do like scans every other year, or just make sure that the patient's seen, get a history and physical and labs, seen by their doctor, and then scan if they're having an issue. And then, can skull-based chondrosarcoma recur and spread to other areas, such as soft tissue? There are many kinds of chondrosarcomas even. There's extraskeletal, there's mesenchymal, there's myxoid, there's conventional and high grade and low grade. So depending on the subtype of chondrosarcoma and the size, then it's possible it can come back. Some it's very rare, it can come back. Others it's a high risk and it needs to be monitored closely. And is dedifferentiated chondrosarcoma rare? Yeah, dedifferentiated chondrosarcoma is rare, but not rare enough for me not to have patients with it. And then, is undifferentiated treated the same as poorly differentiated? I would say that, yeah. And then, should biopsies always be done for a mass? Say a mass in the hand went right to surgery as thought to be benign, should the biopsy had been performed? Depends on the size of the tumor and what at least an MRI could have been done. Yeah. Okay, and how rare is epithelioid? And is it unclassified? No, epithelioid sarcoma. There's a true epithelioid sarcoma that has a specific gene mutation. It's one of the rarer ones as well. I would say 1 in a million. It's considered one of the rare, but actually there's a treatment for epithelioid sarcoma that's been FDA approved. it's not considered unclassified. Now, sometimes there'll be a tumor that says like spindle cell and epithelial cell sarcoma. That's different than epithelioid sarcoma. Okay, and I think we got all the questions. So I just want to thank you. I want to thank Sarcoma Alliance. I'm just excited. This is the 6th annual Sarcoma Exchange. I can't wait to have it in person soon. And want to thank all the patients for being so patient. You wonder where the patient comes from, the term patient. And then I think I'll be available for the question and answer session, whatever they tell me what time I'm supposed to be there.